First, I'd like to start out and thank Dr. Chagares, who is obviously here to speak to us tonight to give us some more education on robotic mastectomy and let you guys know the ins and outs and answer all your questions. As obviously technology is changing, we're so grateful that our physicians are so dedicated in making a difference to all of us women who need it, as well as men. I personally saw Dr. Chagares' post on Instagram, and I think within 5 minutes, I was on the phone with him. And just said this is an unbelievable procedure. I wish it was around 3 years ago when I had surgery, but now it's the next generation, so everybody needs to learn and be educated on it. With that being said, I'm Tracy Milgram Posner. I'm 35 years old. I'm the founder of Robotic Strong. And I'm here today with my co-host Lisa, who's in the back, who's a breast cancer survivor in Long Island. Cancer survivor as well. She has a cancer survivor. She has a podcast. Lisa's also an author of 3 books. I have Shirley, who's just a thriver, who thrives on any information you give her and loves to learn and educate. And then I have Robotic, who is a comedian and also BRCA positive and is an author of a book. As we sit here and talk more, have a lot more in common than I even thought. So she was actually diagnosed around the same age as me, just had a baby a couple months ago, and wants to make a difference as well and educate everybody. So I'll give you guys a little bit of background about myself. I, at 18, had my first lumpectomy. At 19, I had another lumpectomy. At 21, they're like, we want to do another one. I said, I'm not a whoopee cushion. Unless you think it's cancer, we're not doing it. Followed on my doctors for a couple months. So there has to be another alternative. My alternative was genetic testing. Whoever thought, right? 14 years ago, BRCA was not really heard of or known. Studies were just beginning. I came to NYU, I went to Cornell, went to a couple other colleges. Nobody knew what to do with me but say, here's some tamoxifen. For those of you who don't know what it's for, if you have cancer, it's one of the medications that they do give you. Dr. Chagares will maybe share a little bit more information on tamoxifen, as I'm not medical. And I didn't want to do that because I knew that I wanted children. So here I was at 21 diagnosed. What do I do with life? How do I go about it? Just graduated college, didn't know where to go. So I decided to go under some surveillance for the first year. It was great. I went every 6 months. Then things became a little different for me. They found some other spots. They weren't sure. I had every 3 months. So every 3 months for 2 years I was screened, got pushed out, got graduated back to 6 months, thought I graduated, right? Then all of a sudden they say, we want to do another biopsy. And I say, I'm not doing it. I'm going to get married, have kids, have a hysterectomy, and have a prophylactic bilateral mastectomy. So shortly after diagnosed, I got married. I had a girl and a boy, 9 and 5. And then I had my hysterectomy when my son was 2 years old, robotic, which was an amazing way to go in, similar to our robotic mastectomy. My healing, my everything was rather quick. I got to get back up and go back to work. I did have one little setback. I did look into my position and decided I was going to be a superhero and start to lift and had a seroma. And then just got back up on my feet. And 6 months later, I decided to have my prophylactic bilateral mastectomy. Prior to having my mastectomy, I was very involved in research as my background, and I decided to see what other options were out there besides saline expanders. I was not a candidate to keep my nipples, so I had to go look at other options. From there, I found air expanders, which is a new product. Instead of using saline expansion, where you go to your doctor's office twice a week and expand your breast, I actually was able to do it in the comfort of my own home. I was able to go on vacation, even let my little daughter do it because she thought it was cool. Through that process, I got an infection and had a fluid buildup, so they had to go in and remove one of my air expanders. I had one saline, one air, so I was able to help other women by knowing what the difference is, how you feel, how you have to take time off work. You have to go to your doctor's office instead of just doing it in your own home. I went on vacation, I was able to expand on vacation. Through that, I was then flat chested for 6 months on one side. Walked around, didn't have any options, didn't know there was prosthetics, didn't know there was gorgeous little pillows that I could stick in, didn't know there was bras, didn't know anything. So I should back it up a little bit, sorry. Like 6 months before I started my surgeries, I started BRCA Strong and didn't know if BRCA Strong would bring me today. I've grown it over almost 3 years. I have about 2,500 women in my private group, and I have a great following on Instagram, and I continue to educate all of you guys. My goal is to bring everybody together because nobody should feel like they're alone, and your children are a huge role in our lives. They need to be educated. I know, for example, my daughter, I gave a book to recently that was just absolutely mind-blowing for all of you that are BRCA positive or even have breast cancer or ovarian. It's called Proactive Genes. It explains to your children in their terms what it is to go through something like this. So if you have little children at home, I highly recommend it. It's very touching in every way. So here I am today, 3 years later, at an event out of state. I was honored again to work with Dr. Chagares and share my story with you guys. So now I'm going to have Dr. Chagares come up and go ahead and educate us some more on robotic mastectomy and share all the information with us that he can.
Thank you very much. And first off, I think we need to give a big hand to Tracy.
Yeah.
So much. I mean, honestly, if I could be doing this, but no one could possibly know about it hardly. So through all these links and all of your people and all of BRCA Strong, it's one of those things that just was a perfect link together. So thank you very much.
Thank you.
It was awesome. So this is kind of a new dawn of a type of surgery for mastectomy. For 23 years, I've been a breast surgeon. Started medical school in the 80s when there were still some radical mastectomies being done, which is all the breast, all the muscle, every lymph node. And it was terribly disfiguring. Almost every person got lymphedema or a swollen arm. And it progressed to a modified radical mastectomy where we took only about half the lymph nodes, or they did, because it was still kind of that point. I was still a student learning, which cut that risk of swelling of the arm down, but really to 25 to 40%. So, 3 or 4 out of every 10 women would still get it. Still taking a lot of breast tissue and all of the skin. And it evolved. All of a sudden we started saving more and more skin because we realized, I have to take all this skin. Why are we taking all this skin? And then came the idea of having nipple and areola sparing surgery in the proper patients that didn't have a tumor up into the nipple or in that manner. So that also came about. My sister-in-law was one of the first people to have a nipple and areola sparing mastectomy in the initial trials that were coming out of New York here. What was that, about 15 years ago or so. So it's been an evolving practice. In the same time, we've been taking less and less lymph nodes. And if you've heard of sentinel lymph node biopsy, that's the way we can biopsy the first 1 or 2 lymph nodes. And if that has no cancer for cancer patients, you don't have to take any more lymph nodes. So if there's 40 lymph nodes and you're taking 1 or 2, the risk of having the arm swell is very little. So that's progressed a lot. And the surgery progressed a lot. And we were able to save skin and nipple and areola and everything. But then came this revelation because about 5 years ago, robotics started in general surgery, and I jumped on the robotics part too as the other side of my practice. So I do robotic surgery and I do breast surgery. And in the last few months, I was blown away. And I think it was my wife who put it best. She's like, I cannot believe the 2 things you do are literally intersecting into one procedure that can be so great for patients. And it was one of those things that you hear about and it sounds like a good idea. But being a surgeon who does robotics and breast surgery, I said, all right, I have to go see this because I didn't really know if it was something real. You know, you can't really tell. You can read about things, and so flew to Italy. Dr. Toesca, who pops up every once in a while, we'll catch him next. I spoke to him on the phone, and he invited me out to Italy. So I flew to Italy, and he showed me the procedure and taught me how to do it while I was there in Milan. Here he is, right here. I knew he would pop up. And it was a really great experience because he started robotics when he started breast. So he had to get through the robotic kind of phase of learning. And so he was interested to see someone who already knew robotics who could just walk into a mastectomy and start doing it. It worked out really nicely. Within minutes of watching him, I could tell this was the real deal. It was because they didn't change the procedure at all. It's literally the same operation that we do, just through a smaller incision placed way off on the side. And again, the patients who can spare the nipple and areola. So it's a 3 centimeter or a 1 1/4 inch incision placed on the latissimus muscle, the little muscle on the side there. And it was interesting because we were sitting there going, we used the robot and the scope for so many things to make smaller incisions. I mean, gallbladder was 1990, the robotic hysterectomies where patients can just recover that much easier. The camera's in there, your hands are there, it helps you do things you can't just do. And that's why often people say, what does the robot do? The robot can do things with its joints that your normal hands and wrists can't do. Like my hand can only turn half a turn. That robot can turn 1.5 times. So I can put a stitch in and loop it all the way around and have it come back out the other side and then magnify the amount of hand movement to robot movement so that I can have a half a turn be a whole turn. So it's very precise, and you get the camera in there, it's magnified on such a big vision that you get to see so specifically what you're doing. And literally, it was the same operation. Mastectomy, and for anyone, I don't want to get too technical or gross for patients, but for the patients that need a mastectomy, literally you have to basically get underneath the skin but on top of the breast, and then under the breast but on top of the muscle. And you have to get it from both sides and then take it out. It's the same operation as we would do with the incisions on the underside of the breast, or the omega ones, the ones that go around the nipple on either reverse or the upper one. And it was the same idea, literally take the 2 planes down and take the breast tissue out. So the fact that he didn't change the operation at all, but just used a different tool to do it, was the reason why I could tell it's immediately something that is a winner, and it was going to be the next step in this. So as soon as, we were there, and even the first day when I got out of his OR, I was talking to my wife, I'm like, this is it. This is exactly what we had thought it could be. But it's just a matter of, was it really that? And it totally was. So as we started learning about this, and I learned more, and he taught me how to do it, then we came back to the United States here, and I said, all right, we have to get this going. So we started a program, I started seeing patients, and we had our first patient 1 week ago, and she's doing fantastically. She got her drains out today, and she's
Good for her.
And she is surprisingly literally around the corner.
She's coming.
She's coming.
Yes.
She got on a train. She lives in Philadelphia. She got on a train just an hour ago at 6:20, and because she had to see her get the drains out today and all that, so we had her do that down near there with some of the other plastic surgeons down there. So she is off the train and is coming here, and it was kind of a big surprise for us, because then you really get to see someone who's literally 1 week out from this procedure.
Right.
And
Yeah.
she's just, you're gonna love her. If anyone saw her little videos online, she's she's the greatest little patient. She's fantastic. So you're gonna love her. But that being said, the surgery itself is, I mean, there is the one side that you can do a mastectomy and get the breast tissue out. There's the whole other side, the whole psychosocial part about being able to wake up from anesthesia and look down and see just what you've always seen, the skin, the nipple, the areola, but literally no scars. And the way we make the scar is we have patients stand and we make a little line with a marker, and then we have them move their arm, and then we put the incision behind that line, so that way when they're just standing, no one would ever see that incision. You'd literally have to go like that to show the incision.
Wow.
So it's, that part alone is fantastic. The other side of the coin is for patients who've been through this, when you need the other route with the expanders, you get the expandable implant put in often, and then it takes weeks and months of expanding and stretching the skin out, even if you did a skin sparing mastectomy, because normally those implants have to get put below the muscle so that they just don't, well, so they don't fall out, for lack of a better term. Because if you just have skin and that wound opens at all, the implant will be just right there. So they always had to put it under the muscle, but the muscle sits on the ribs. If you tried to put a whole implant in under the muscle, that means you have to stretch that muscle all the way up. Sometimes you can do it if you have a smallish, like an A-cup implant on someone. But it's very difficult, and the discomfort is a lot more. When you start dissecting that muscle and taking it off and stretching it, that's usually the part that hurts on a mastectomy. The breast tissue doesn't hurt as much. I had the best, worst call on a Saturday morning, 2 days after I did an 85-year-old woman's mastectomy. She had breast. She didn't want reconstruction. That's okay. I understand that. But she called the service and said she thinks she had a stroke. So I call her back and I'm like, oh my God, this is like. So I call her and there's no slurring in her voice. Okay, good. That's a good start. I'm like, well, is there weakness? Is there a facial droop? No, not anything like that. I'm like, well, what's wrong? And she said, well, I just don't have any pain. So I must have had a stroke. I was like, oh, that was awesome. That was the best part. I was like, because if you literally don't have to tuck anything under the muscle, you're not stretching anything out, and the skin was naturally there anyway. So without any tension, there wasn't a lot of discomfort. If you think about it, like a little kid who gets a little cut on their arm, who gets stitches, they don't need pain medicine and they're not laying around. You have to hold them back from playing still. So there's a lot less discomfort when there's not a stretch or a pull. This version of mastectomy, once I get the breast tissue out and the mastectomy portion is done, the breast surgeons can put the full implant right in because you didn't disturb the crease of the underside of the breast. And in doing so, you can put the whole implant in, and because you didn't have any incision on the skin, you can put it on top of the muscle. So you don't have to stretch the muscle up. So you put it in and close the skin, close the incision there, and it just basically is tight and firm, but that's, you know, and so this patient, and you'll meet her, woke up and looked down and was like, wow, that even is more perky than, because they certainly don't make saggy implants. They make choice, that's what you want. So it's one of those things that even her daughters were like, what? This is not fair. This is so. That's kind of the other nice side of the coin, is that part. Some of the things I didn't know that would happen that's more technical is, first off, when I was doing the surgery, what we always do is biopsy the tissue. Even if you're a BRCA patient, even if it's the other breast and they have cancer on one side, we always or I always do, I don't know if everyone does, but I always biopsy the ducts that are going up into the nipple. When I have the scope in there, it is on, what, a 40-inch screen? The nipple's, what, a quarter of an inch wide? It is a foot wide on our screen. And you can see literally the ducts coming down. And we have a special vessel sealer that we use that we can seal blood vessels with, and I can literally biopsy the tissue that's exactly below where we're leaving, so that we know we're not having cancer come up into the ducts. That's one of the contraindications to the leaving the nipples if you have cancer in the nipple. So that was something that really hadn't been part of my thought pattern when I was looking at this, but the surgery with the robot actually makes it a little more precise to be able to get that tissue exactly. I don't think anyone's ever not gotten it, it's just you end up getting a bigger piece when you're not doing it robotically, and you can get exactly what you need. The other side of the coin that I also figured out was that it gave you a nice ability, because the scope has a straight scope, and then you can look up or you can look down. There's different angled views. So you can literally look up at your skin and make sure you got all the breast tissue. You can look down at the muscle, make sure you got all the breast tissue there. For the patient who's coming, she had a tumor near the muscle, so I was able to take a little muscle and literally make sure all the margins are clean. So there's some technical sides of it from the surgeon side that I was able to see works really nicely too, and was, I think, an advance from the open version that we do, because when we do open, we still make a smallish incision. We try to make it as small as possible, but of course it has to be big enough to be able to reach your hands in, as opposed to little instruments. So it was just one of these things that when I saw it, I said, this is such a great advance, and then after doing it, I could see even that much more that I liked about the procedure. What can I say?
Let's talk a little bit about Dr. Elwood. We're going to leave the Q&A for the end.
Oh, good.
And well, once Dr. Chagares is done, and a couple other people are going to speak, but Dr. Elwood was not able to stay with us.
Yes.
Who's the plastic surgeon, but his surgical coordinator, Tara's here. Maybe I got it wrong. That's Tara, she's here. And then Dr. Chagares is both of his office staff here as well. If you guys have any questions.
That's
for
my
Dr.
wife
Elwood.
back there too. Yeah, I know Dr. Elwood had a run, but he did, I can tell you, because he said, listen, let them know about our, the reconstruction part, and that's why it was so exciting, that literally that other side of the coin, the reconstruction, is able to be done one step, full implant, it goes in. For the ones, I had a couple questions about alloderm that's still able to be put in. It's a kind of like a little sling, almost like an internal bra that keeps the implants from falling out to the sides. In the old days, like when they first started, a lot of implants used to fall into the armpit area on patients, and they'd have to have a lot of revisions. So this is so they can do all that through the same little incision there, and get the implant in. And literally, like we were talking about, to some of the patients, there's one drain on each side. Often there's two when you have to have more skin incision. So with one drain on each side, I think anyone who's had a drain, if they can have half as many drains.
That's an understatement.
Being able to have 2 versus 4 is a big difference too. So there's a lot. This is the plastic side of it, or the reconstructive side, is kind of falls right into place. This was a typical incision that they apparently used to use for women who wanted an implant just for size increase, and it used to be one that they could tuck one in on. So it's not something new for them to do, and so thankfully that wasn't another step in this procedure. Once I was able to finish the mastectomy part, there's an incision and an open cavity in there. It worked out perfectly for him to be able to put the implant in and have it sit nicely. And then we close up the wounds, the one drain. There's this thing that looks like an oversized Band-Aid, and the next morning you go and see the patient, and literally, other than a little bruising on because of taking away the tissue, it's literally the incision's over here, and she's sitting there in the bed looking wonderful, and I was just smiling from ear to ear, because I could see what a difference it is. I mean, that's really what it is you can have a mastectomy anyway, But if you're a candidate for nipple and areolar sparing and you can have no incision on the breast and have a one-time full reconstruction, it just seems, it's just, like you said, it almost sounded too good to be true until I literally saw it and said, well, it's the same thing we said about gallbladders when we used to make a 12 or 15-inch incision here and people would be in the hospital for weeks on end. And then we changed to using a scope and those people got out the same day. And slowly but surely we've been using the scope and the robot to do things through smaller incisions. And it was kind of a natural next step and it's just really exciting. So his, Dr. Elkwood's, and the reconstructive part kind of fits right in so nicely for us. So,
Thank you so much.
definitely.
Thank you.
Thank you.
I figure everybody is done speaking, if that's okay with you guys, unless you guys are that anxious while he's up here, you're more than welcome to ask him a question.
Like, and we have a couple potential patients here too, so that's.
Thank you guys all for Brackish Job, whoever came from out of state. I'm truly honored. Stephanie, it was a pleasure meeting you.
Same here.
In person. Laura, you as well. Some of my ladies actually are not from New York and have come out of state, so I'm very honored and I feel very lucky to have you guys as part of my group, because I know when I first started, I was not this honored to have a table full of women. Look at one side of our room, there's one gentleman here. This side, there's one on the other side, but when you turn around and look at a table of 20 women that you know you can call anytime. There's nights where my phone's ringing at 2 or 3 in the morning and I'm just in heaven. I mean, as crazy as that sounds, that I know that I could be there to support somebody just makes a really big difference for me. Next, I'm gonna call up Kelsey, the cancer survivor. And just so you guys have a little bit of background about the girls in our relationships, Kelsey and I actually met about 6 months ago. I went to the Young Survival Coalition in Orlando. She's from Ohio. We happened to meet there, and ever since then, our relationship has drastically grown. I obviously am a survivor. Kelsey's a survivor, so she can help some of my survivors as well work through some of their processes. That, you know, of course, I'm here to support you guys, but there's some feelings that I can't express because I didn't have to go through some of the battles that you guys went through. So I like to bring my survivors and providers together.
Yes.
Yeah.
Woo!
And of course, I want to thank you so much from the bottom of my heart for letting me be a part of this. This is so great. Give me a hug. I love you so much. You know, we met back in February, actually, when we were at the Young Survival Coalition's Summit event. And I went because I needed a lot of answers. And the big problem with being a young cancer survivor is the lack of resources and availability. And it's just not given to you right away. And as soon as you hit that diagnosis, you get that diagnosis, things just move into fast motion. And you're suddenly put into treatment, you're suddenly put into chemo before you know it, and your life has just drastically changed. You know, you go from living life to suddenly going to doctor's appointments 4 days a week. You know, between all your multiple doctors, whether it's your oncologist, your general surgeon, some of you are nodding your head, you know. And it can be really daunting because suddenly you're a patient and your identity, you know, as to who you are completely changes. And so when I came out in February and I met her, I saw how much she was doing for the Rocket community. And even though I was negative myself, I did, you know, get myself empowered to find out what I had and whatnot. And as it turns out, I don't have any genetic mutations. So it's kind of like, for me to get my diagnosis, it's kind of like, well, it's just something that happened. So through meeting her, I started in April a podcast called the Cancer Survivor Podcast with Kelsey Smith. So I have been doing that. It's a weekly show where I interview either a guest or I do a solo episode. And I talk about all the caveats of breast cancer and what it entails. And I also interview guests. So for instance, Tracy was my episode number 2. She was my first guest on the podcast. And in episode 16, I had Miss Lisa on also. And so I I love to look at individuals who have turned their situations, their lemons into limoncello, I like to say, and really, you know, do something to, you know, whether it's empower the next person or inform the next person, or just to talk about their experiences so that somebody else doesn't have to go through it also, or just to not feel alone, because, you know, one of the missions of Tracy's organization is to eliminate the feeling of isolation, which is really one of the top issues that we go through as young people, because in the real world, the regular world, you don't typically hear about individuals having cancer in their 20s, you know, or a diagnosis, you know, that young. So pretty much I love, you know, interviewing people and getting to know other people's stories, because we all learn off of each other. And I'm glad to be here to be able to facilitate a Q&A so that we can learn and we can really be empowered. And on top of that, we can start spreading the information around to people, because, you know, really the unsightly scars, the insecurities that we face, you know, the way that we feel so mutilated after a typical mastectomy, really, it's not, I wouldn't wish it on anybody, truly. So, you know, finding out about the robotic mastectomies has just been, it's just mind-blowing, really, and it just opens up so many possibilities for healing, and I can't wait to learn even more. So thank you guys.
I want to make a long story
Spotlight.
funny and short. I hosted an event for Hairdex. I don't know if you guys are familiar. Whoever is BRCA positive, you should follow them. They're actually doing research on the upcoming for children. What's going to happen? Are we going to give them a vaccine? Can we give them an oral medication? So here I was at this event. They came from California. I hosted it in Florida. Here I was in the bathroom. Angie apparently thought I was a photographer. And here I am, 6 months later, honored to have her as my friend. She's not only a survivor, she's BRCA positive. So she's a big advocate and supports me in everything that I do. I probably see her more than I see a lot of people. So if you guys ever need anything, she's a survivor, and again, she's BRCA positive. She helps us share education and is very supportive of us.
Angie, stand up. Come on, stand up, Angie. Woo! Yes.
Next, I'm going to call up Lisa. I met Lisa through Kelsey. I was honored to be introduced to her. Today is the first time we're actually physically meeting in person. We've had a lot of communication going back and forth, as she's the co-host to the event, but she is obviously in Long Island, which is different because Staten Island, because I'm in Florida. So I'd like to introduce you to her. In your bag are books that Lisa wrote. If you guys would like your book signed, we'd love to sign it. Not me. She would love to sign it. It's tired. So I'm going to pass it over to Lisa for a couple minutes, and then we'll continue on.
All right, so I just want to start off by saying thank you so much to Tracy, to Kelsey, and of course to Shirley, and to all the beautiful, amazing, wonderful survivors who are here tonight, whether you're pre-virus, survivor, the men who are here supporting them. I love you all. You guys are amazing. So I'm going to keep it really brief. I'm a breast cancer survivor. I got one boob, so yay!
Hold on. You got it. Lisa, what's your line on Instagram? You have to
You can
repeat
still
it.
work with that.
You have to repeat it. So 1, 2, yeah, but.
Oh, I'm like
gotta
the
say
one
it.
thing.
You gotta say
I don't
it.
give a shit.
But
No, this is it. Wait. Okay, I can do the my cousin Minnie thing. Imagine you have a little girl, right? Okay, so imagine you have a little girl. You get diagnosed with breast cancer. You got 2 tits. What are you gonna do? You cut one off, right? That's true Staten Island.
So when I saw that, I said, with that attitude, she needs to join my team.
Yeah, I would say, but I mean, it's an honor to be here. I run my own nonprofit, and my focus is on helping people who are survivors have tools to get back to work. I lost my job the day after my last chemo. It was like, oh, you know, you're back, chemo's over, that's great, we don't need you anymore. It demoralized me. It made me feel like, you know, I was bald, I was wearing a wig, my kids were 6 and 9 years old, and it basically stripped me. Like, I was now just a cancer patient. You know, I no longer had a job. I could no longer say I was a job. I was now just a patient. And I figured, okay, I'll find a new job. I wrote books before I got cancer on how to find a job, on how to interview. So I figured, no problem. I lost my job, I'll find one in 2 minutes. It's good. And then all of a sudden I realized I got one boob. My hair would never be this short. I always said not too short. I look like my brothers. I was still the pretty one. So I said, listen, if I'm having so much trouble finding a job, and I wrote a freaking book on how to do it, if I can't do it, what's happening to everybody else? So obviously I still couldn't find a job, but I made one. So I founded my nonprofit. It's called Balance After Cancer, and the book that's in your bag is about how to be work ready after cancer. I also wrote 2 workbooks, and I have a free online class. It's at balanceaftercancer.org. You don't need to show me your oncology report to join it. You just go in and you learn some shit, right? I've been a professor for 15 years. I worked an executive in New York City. I've been an educator for a long time, and my goal, as much as I want to say we all want to move on, it's not easy, right? Everything changes about us, how we think about things, how we process things. So I got my business cards, everything's in the bag, and I hope you all find meaningful work because, dang it, we're worth it, and we are survivors.
So, at this time, what I'd like to do is everybody go ahead and look that way as we have an amazing woman who is extremely powerful, strong, inspiring, empowering. And we're honored to say Dr. Stephen Chagares is.
One moment.
So, Ivana's going to be coming through the door with Dr. Chagares. I'd like everybody to stand up for me and give her a very big welcome when she walks in and let her feel all the positive energy and love that we have for her. Since we're all standing here patiently waiting. Oh, they must have known to look pretty today. Really quickly, ladies and gentlemen, I just want to again thank my friend Shirley, who is right here by my side, who's actually has an amazing project going on right now that we'd love for everybody or anybody that's interested. It's called Women Empowerers. Really quick, brief background. I met Shirley about 2 years ago. 3 months before she told me, I'm leaving to Spain. We developed this amazing relationship. In 3 months, we spent day in, day out, every day together. Through her Spain trip, we kept in touch, and here she is with me today. All right, ladies, come on in. To see you. Thank you so much. Jamie, thank you so much for coming. I really appreciate you coming.
We also do. So, this is our patient that we had last week. Oops, sorry. This is Yvonne. And last Friday, 1 week ago today, we did a robotic.
Sure didn't look like this.
No. Let's move those arms around for us there.
All right.
I mean, literally, this is so fantastic.
Oh, so good.
Honestly. So she's been doing fantastic. For anyone who's been through any of this, to see that kind of movement is just wonderful.
Wow.
So, I know. Not really. Right.
Moving.
But yes, we're really honored because Yvonne lives down in the Philadelphia area. So they took a train up and literally just got here right now. So
Amazing.
yes.
Here's just a little something for you.
So, yeah, so you can see how it's more than just surgery. It's here, so. I'm so glad you came today.
Virginia, you want to come in the picture too?
Okay.
And this is her daughter, right? Your daughter?
Yes.
Yeah. This is her daughter who has been in touch with me on Instagram and on Facebook and has shared her story and her information with us. So what we need to do is continue to educate our community, make sure these stories are shared, make sure that we educate everybody, anybody that we can, BRCA positive survivors. Let's just truly make a difference in everybody's life that we can.
Yes, yes, well, I didn't hear. This is so wonderful that you got this together. Why don't we?
Yes.
If it wasn't for Tracy, so.
Fine.
Yes, thank you so much. All right, I wasn't expecting that.
That's why I reached out to.
Right. Well, you can see how this is like, it's so nice to be able to do that. I mean, I tell my little daughter every night I get to put my head on my pillow and know I helped someone. Took someone's cancer out, fixed something, whatever the case was, and I just really feel lucky I get to be able to do this as my
feel lucky that I had it done.
I was actually able to see some of the videos from Dr. Chagares' phone that I have to tell you guys was mind-blowing. I'm going to share pictures later with you guys that were taken as I watched the video. And being a patient that wasn't able to keep her nipples and to know that, 3 years ago, oh, well, you can't do it this way, you can't do it that way because you're going to get breast cancer in your nipples if you keep them. To know that as a female, that the next generation will not have to experience what I did. It's just, I'm speechless.
We're all getting that up here.
So what I'm going to do is, I'm going to open it to a Q&A because I'm honored enough to have Caitlin here.
Yes.
For those of you guys who don't know who she is,
yes.
she wrote this awesome book. She is selling them for $16. You guys can also get a signature from her if you'd like walking around. She's going to close it with her comedy that's built in her story that I've been waiting for, I think. So how old's your baby?
He's 7 something.
So I think my first event, I invited Caitlin to Florida.
Yes.
And she goes, I'm pregnant, I can't come. I said, don't worry, we'll have time to meet again. I reached out to her this time, and I think within an hour, she answered and said she'd love to be a part of this event. And I figured there'd be no better way to end an event like this with some comedy.
Yes.
She's like, that's good.
Just drink a little more. That's how I like my audiences.
Waiters, pour.
There you go. So at this point, what I'm going to do is I'm going to open it to a Q&A. If anybody has questions for Yvonne, for Dr. Chagares, for myself, for any of my survivors, or anybody in the room, we'd love to help you. We're here to support you. One other shout out I did forget to do. Can you stand up for me, Joanne? Oh, yeah, Joanne. I have a very close relationship with a lot of my physicians in South Florida, and I was honored to meet Joanne almost 3 years ago, and I've always attended her events. Her husband, my first speaking engagement I will never forget in my life, in the middle of 100 people, I had no idea who they were. Tracy, you come here. And I said,
Share your story.
Share your story. And it was so emotionally hard for me that Joanne actually took over the microphone and told my story. Wow. I called her and told her about my event. She shared it with all her family and friends. Saturday and Sunday, Joanne has Pink Angels. They are coming to walk. They'll walk with us Sunday at the Brooklyn Bridge. Tomorrow, Boobs and Bagels. Joanne opened her home to me on Wednesday night, coming in from Florida at 11 o'clock, and I'm truly honored to have her as a guest here. She does events locally in Jersey. She's very involved in different organizations, and she supports nonprofits.
Yeah.
Ron should hear you now. You are speaking
Aw.
beautifully. Wonderful. So proud.
All right, so I'm going to take over for a minute and say to Tracy for bringing this together and showcasing herself. All right, she's definitely deserving a BRCA survivor, and at this point, someone to be inspired by.
So at this time, who has some questions? Are they for anybody specific? I know Kelsey, you had a question for Dr. Chagares. I'd love to open the floor to you first.
All right, so my question is, so in 2014 when I was diagnosed, I went through the traditional bilateral mastectomy and everything. And I was stage 2, I had invasive ductal carcinoma, which is the most common form of breast cancer. It is the cancer of the milk ducts. So my cancer, for example, it was located around the 4 o'clock region of the breast. You could clearly see the milk ducts, it was discolored. And also, my nipples were inverted, and so they were always kind of inverted except for when I was full. But then, when I had the actual tumor, no matter what, it wouldn't protrude. So, in situations like that, what is the likelihood of being able to spare the nipple when it involves the milk duct?
So that's an interesting question. Yvonne had one close to the nipple and areola complex. So one of the options is to do chemotherapy first, or neoadjuvant chemotherapy, which can shrink the size of the tumor, and then in doing so, sterilize the area and potentially make you go from a candidate who could be a nipple sparing from one who was not beforehand. So it's not guaranteed, and like we were talking about, you have to biopsy the tissue right when you're doing the surgery. But that's done in a frozen section setting, so we know right then and there that it's clean, and then we know the tumor is backed away from it. The other thing is, because the nipple's inverted, it doesn't necessarily mean the tumor's up into it. The nipples often get pulled down by the ducts, and the tumor can be set back a little bit and be pulling the nipple in, and by pulling the ducts, but not have cancer up into those ducts. So especially in that case, if you can do neoadjuvant or chemotherapy before you have surgery, and then all of a sudden the nipple goes back to normal and it's not being pulled in, that's one of the indications that you probably clean that area out enough to be able to save the nipple in the area. So it is possible, and that's one of the options, is to switch it and not do surgery first, but do chemotherapy first.
Thank you.
So the nice thing about that is often people have to have a portacath put in for chemotherapy. It's an implanted IV. Yvonne finished her chemo before, obviously that's what's before surgery. So when I was in with the robot, and the port's always put in the opposite side of the tumor. So when I was in doing the right side, I was able to actually take the port out from the inside and not have to reopen her incision on the chest. Because take the port out like robotically, so to speak, so that could come out at the same time.
Yes. Yeah, many of us have these scars.
Right.
Yeah.
Exactly.
And if you don't mind, to kind of piggyback a little bit off
Yes.
of Kelsey, in my situation, BRCA positive, where I had the most aggressive form of breast cancer, and my breast surgeon recommended chemo first. Well, I had my port put in, but he also recommended, along with my entire team, that I spare my nipple. So that wasn't, obviously for me, you know, that wasn't the deciding factor. I was gonna fight. This is what we're doing. But in a case with triple negative,
Yes.
genetics and into place, would you recommend someone like myself? I was 50.
Even when you spare it. So one of the things I always enforce with patients is that by doing a mastectomy, some people think, and because they're just, that if you have a mastectomy, that there's no chance you can ever get breast cancer again.
Right.
There's still a little breast tissue that lines the skin of the breast anyway. So depending on the size of the breast, it's anywhere from 2 to 5% of the breast tissue is still left. So my theory is that if you're leaving 2 to 5% anyway, then leaving the nipple can't be more than about 0.2% of all the breast tissue there. You're leaving very little more. And it's the most easy to examine portion of the breast, especially after implants are put in because it's held up so nicely, that you can examine yourself and do good self-exams to make sure there's nothing that's growing there. So I think even if you're BRCA positive and you had cancer and you had the mastectomies, you can consider keeping the nipple areolar complexes if you understand that it does increase the risk a little bit. But I keep hearing the term mutilated from this surgery, and I mean, I almost feel uncomfortable saying it because you almost have to be the one who owns it to be able to say that.
Right.
So it makes me uncomfortable to say it, but I hear everyone say it. And the fact that you have no scar on the breast this way, that's such a psychosocial difference in the way you just can go about it, that I think that if you're already are leaving yourself a small risk of getting breast cancer, leaving a little more risk, but taking a lot of weight off your shoulders mentally, I think that's where you start weighing the risk-benefit profile on things, and I think the benefit of saving the nipple and areola probably far outweighs the risk if it's truly no cancer up in there and it's off to the side and it's truly clean, like you were saying, you fulfill the right requirements. So that side of the coin is that you're always leaving some risk. So accept the amount of risk you want versus the benefit, and I think that each patient has to make that decision. That's why it's important to spend a lot of time with a patient to figure out what they want. I mean, I have patients who walk in and they have the tiniest little tumor that would be fine to do a lumpectomy on. I mean, there would be perfect one, that's what the operation is for, and they immediately say, I want both breast removed. And they've already decided that. So it's not my place to not decide that. They get to, that's one of the options here. One of the things that surprised me in Italy, was that they can't do the other side prophylactically because it's government-run medicine, and the science shows that you live the same life length, the same life expectancy, whether you do one or both. And that's why you can't put that side, oh, you'll live longer. You're not going to. You can live a different life though. Because if you have the other side done, you're not getting mammograms and MRIs and reliving the kind of the PTSD of the first diagnosis.
The side effects. What do they say? And from Italy perspective, what is the highest side effects from patients after having this procedure done? Are there any?
You mean post-operatively?
Yes.
I think more of it was the surprise that there wasn't as much pain or discomfort as a lot of patients had from the standard way, because the implant often can be in front of the muscle. And literally, just the surprise of just looking down and not having any scars. So the patients are moving. I mean, you can see the way Yvonne moves her arms around. If anyone had mastectomies and implants, and you don't look like that as you get usually. But that's one of the nice parts of having that done that way, and they get back a lot quicker movement and a lot less discomfort too. So it's kind of nice on that side too, especially for patients.
You got a question?
I do. I have a question. I'm a stage 3 breast cancer survivor, and I had chemo first. So
Yes.
it gave me a lot of time to discuss with my surgeon and with my plastic surgeon all my options as far as reconstruction. And I actually chose to have a deep flap. So someone in my position, would I have been a candidate for a robotic mastectomy?
Right, so here's the thing, if you're going to do a deep flap, then by definition there has to be some cutting on the breast. And once that incision's there, you kind of lose the effect of the robot.
Right.
I don't think anyone's combined deep flap with robotic without making any breast incision yet.
Okay.
It would, because part of the deep flap is the skin part.
Right.
So therefore you have a skin incision there.
Right.
Maybe we can invent something.
Well, I have a question now.
That's
And
nice.
I went to, 2 weeks ago, there was a physician in Miami that does something called the RAVA.
Yes, that's.
So like how so for example, he has his own expansion system, which is a little different, but he takes your fat from wherever you are, he liposucks it out, and then he uses that to create your breasts.
Right.
So like, could you do that
Right.
from the robotic standpoint, do the robotic mastectomy, and then use your
own
liposuction back to create
Right.
your breasts?
See, I don't see a reason why those
Donate
things.
back to
We're doing it, let's go.
You're
We're leaving. We're going on.
But this is how these things come about.
Right?
I mean, literally, people
Think
go,
about
why
it.
can't we use a robot to do mastectomy? And then they start to go like, why can't we use fat that we suck out of here and put over here?
They're just taking it,
So-
Dr. Corey, if you're listening, question for you. Go ahead, you have a question?
She has a question. I have a question.
Yes.
I was diagnosed also with stage 3, and I had radiation right after my simple mastectomy. So how is this procedure, can you use this procedure when you have a patient who's going to have radiation after surgery?
Yes. In fact, Yvonne's gonna have radiation.
Okay.
So, yes, it's definitely, and still, you're gonna get the same answer from the reconstructive surgeons that it does often tighten the skin and they raise the implant up a little bit. I think they've seen less of that in Italy only because you don't disturb the inframammary crease. So there's not a scar that can shrink in. The other nice thing about this is the way scars heal, horizontal scars are ones that go across, by gravity are always pulled apart and get stretched. If you have a vertical scar, it's almost like taking two rubber bands and pulling them in the same direction. They get pulled tighter together, as opposed to having them held this way and pulling them that way. So the scars that are over here, when they heal in a vertical manner and they pull together, and the scarring isn't as wide or as pronounced, just by the physics of wound healing. So that's another completely, something no one thinks about until they're the owner of it. Like, hey, that really faded away to almost nothing because of the vertical nature of the incision. So.
This sounds wonderful. When is this? How long would it take this to become like the standard?
Well, that's a great question. Here's the issue in the United States. Most robotic surgeons don't do breast. And most breast surgeons don't do robotics. So you end up in this quandary where only a few of us do both robotic and breast surgery. So you end up with a lot of the surgeons who, maybe they've had a more recent residency, they came out and did a fellowship in breast surgery, and then come out and be a breast surgeon, but they will never really have trained on the robot, so they can't really do this procedure. And then the robotic surgeons who are doing all these liver cases and pancreas cases aren't really focusing on breast at all. So there's not a big population of surgeons who do both. There's enough of us out there, and I think it's going to keep on catching on. And I'm hoping that I can be part of that. Right, exactly. But that's why it's not as so that's why it's not as prevalent, because of the lack of the two mixing in most surgeons.
I mean, even in an insurance standpoint, like with the insurance company, I'm sure they would be pushing for this because this is like such an advantage, right? Because there's less healing, there's more healing time,
Well,
a quicker healing time.
Well, here's the one thing though. If you and insurance are on the same side of a cost, so you definitely, if insurance sees that this is one stage with an implant, are they going to be saying you should have this done? It may be the case, and this may end up being the standard of care in the future, which would be awesome for this type of patient for all these reasons. But you're right, from an insurance standpoint, I'm sure they would love to have someone at one stage redone, boom. Even if the robot costs a little more, a few $100s more, literally per case, that's it.
Wow.
But if you can switch off all these other operations,
Wow,
it's
that's
not
great.
even.
That's fantastic.
So.
Does anybody else have any other questions?
So I just read something as it went by. What about your time at the White House?
That's awesome.
So,
I saw that and I was like, ooh.
So that was what. So when I was at Georgetown, I went to Georgetown undergrad in Washington D.C. and I needed to get a job because President Reagan axed the guaranteed student loan, the GSL. So I actually got a job.
Did it trickle down? Did it trickle down, did it?
Yeah, it would trickle down.
Ah.
There we go. Yes. So I actually got a job working at the White House, and because there was no time gaps in my little life where I went right from grade school to middle school to high school to college, the FBI, CIA, and State Department could clear me, so then I ended up being the waiter for President Reagan himself.
Wow.
When I was a sophomore, junior, and senior, and I'd have the tuxedo on, and I'd go to the White House 3 or 4 nights a week, and that was my college job.
Yes.
And of course, the first night, when these guys, they're consummate politicians, he looks up and he's, oh, a new face, because they don't have that many changeovers. So I'm like, yes. He's like, what's your name? I'm like, Steven. Because you're not supposed to talk a lot. You're just supposed to answer. He's like, so what brings you here? And I didn't know how to keep my mouth shut. And I said, well, you axed the guaranteed student loan. And like, without it, and the whole table he was at was just like, and so he's like, looks up, and without even a blink, he just goes, well, you see that? If I hadn't have dropped that, I would never have had a chance to meet you. That was such a fun. I'm like, good point. Yes. So that was the best job. We would leave the White House in our tuxes and thinking we were like the coolest. We'd go to the local Georgetown bar and walk in our tuxes. So that was part of that. You know, you gotta live a little while you're learning, and that made it fun too. So.
Awesome.
But yes, that's a little personal thing thrown in there.
Yeah.
So again, we really appreciate all the BRCA Strong supporters, both online and the ones who were able to come here, and Tracy, who's just awesome for putting this all together.
Yes.
Hey Doc, I got one question for you. Two.
Oh, go ahead. I didn't even realize we had more. Sorry.
So, how would this affect somebody who did not want to have reconstruction?
Well, that's a good question. Depending on the size of the breast. Literally, if you're a D breast, there's so much skin, there'd have to be a skin removal part.
Right.
If you're going to do that, then the robotic part would kind of be. On the other hand, if it's an A or a smaller B cup, I mean, when there's not an implant in, and we have those pictures before the plastic surgeon, the reconstructive surgeon comes in and puts the implant, it just lays flat on there and looks very appropriate. You know, one of the other kind of things that's out there is the transitioning patients, who's a totally different group, but you know, a lot of women transitioning to men, that is also going to open up a new option for surgery, because they won't have mastectomy scars. And they can have 2 scars over here, and you know, many times transitioning patients, if they do have the smaller breast, could benefit from that also. So you can take the patients who don't want any reconstruction, but still want their nipple and areola.
Well, I opted out of reconstruction. So I wasn't comfortable with the implant, and the idea of an implant in me.
Right, and I have a lot of women who literally are just kind of like, okay, I don't want to have that anymore, and that's okay. I'm fine with that, and I can still wear clothes, and no one's going to know my business, but I still want to keep my nipples and areolas. And especially I have patients who are if they start off with an A or a near A breast, it's not a lot of difference looking, because the skin gives a little bit of a crease anyway in the cleavage. So it's still a usable option without reconstruction at all, absolutely.
Awesome. So yeah, just touching base on how long is the actual recovery period? Given the fact that we have someone in here who's been here a week out, at this point, that alone gives me a lot of kind of understanding. But how long? What are your expectations on the actual recovery period?
It's all going to be a graduated thing.
Yeah.
Would I want her chopping a cord of wood right now? Probably not.
Yeah.
Let's ask Yvonne.
She probably could.
Share a story. So today, when we were not sure if we were coming or not, so I decided I was going to go out and start cutting the grass. And she's like, I'm going to come out and be with you. Do you want me to help you start? I said, don't even think about it. Not
So
even
she was
think
going to
about
pull
it.
that cord.
I love it.
She could, but that's the problem is that it's a good thing. Yeah, okay, she can do that. So I don't mind this kind of movement. Literally, when I did breast specialty training at Memorial Sloan Kettering, we were actually doing the study, I think it was 1990, where they had 3 different groups of women. One slinged and swathed, like no movement. One told to do minimal movement, and one who we asked them to move the arm fully, do some physical therapy, nothing specific, but just things patients could do. And even back then, we found out that arm movement didn't increase drainage, didn't increase seromas. It's the more things, if you go do that next level up, that you're going to get those. But the normal things around the house, reaching up, brushing the side of your hair, reaching into a cabinet, all those things are encouraged and don't increase the complication rate. So, we're going to have patients who can do physical things around the house within only a few days instead of weeks. We're going to have people back doing low impact cardio and that type of things where you're just doing that probably within a 2 to 3 week period instead of a much longer period.
That's amazing.
And then more like probably 5 to 6 weeks where they really can start doing full arm exercises and be able to really strain the muscles. Because again, the pectoralis muscles are now no longer coming in and then being displaced over an implant. Instead, they're working physiologically the way a muscle should work, hooking up to the sternum, coming straight across the ribs and going out so that you can use it to control your arms and do the type of motion. So in doing so, really, it is allowing people to get back a lot quicker.
That's it right there. That's your example. Thank you.
At this time, we're going to take a couple minutes of a break. Lisa and Caitlin are both here to go ahead and sign your books if you guys are interested, and then we'll go ahead and end it with Caitlin.
Yes, and all I can say is I'm so glad I'm not following.
Yes.
This is much better than before.
All right. Thank you, Dr. Charles.